Without further ado, I'd like to introduce you to PatientMatters CFO, Patrick Chung. Say hello, Patrick.
Good afternoon.
Before joining PatientMatters, Patrick was the CFO with Hospital Physician Partner in Fort Lauderdale, Florida. During his time at HPP, he merged two large emergency department companies comprised of approximately $200 million in annual revenue and combined two credit facilities into a $50 million credit facility term loan with its senior lender. He also completed two ED and hospitalist acquisitions, as well as an accounting system migration to Great Plains. Patrick also did a significant reporting system upgrade. Patrick has an MBA from Lincoln University and a BS in Business Administration from the University of Missouri, St. Louis, cum laude. Next is our Vice President of Finance and Data Analysis, Jeff Toon. Say hello, Jeff.
Good afternoon, everyone.
Jeff is a healthcare finance and accounting professional dedicated to helping a variety of organizations better organize, analyze, and interpret their financial and operating data. He has deep experience in financial modeling, operations analysis, budgeting, and strategic planning, and also metrics and KPI reporting. Jeff is a CPA and a member of the HFMA. Gentlemen, are you ready?
We are.
Take it away.
Yes.
Well, we appreciate everyone joining us for the webinar today. So as Betsy mentioned, our topic is the value of self-pay analytics, and the brief agenda here is we'll start off with a brief market overview. We'll talk a little bit about some of the trends and changes and challenges that are going on, particularly with regard to the healthcare regulatory environment. Then we'll move through an analytics framework with a focus on types of analytics and types of processes and procedures that your hospital can implement, specifically with regard to managing the self-pay balances. Jeff will walk you through a number of different sample analytics that we've used in the past, and we'll close the presentation with some closing comments, and we'll have time at the end for questions. So why are self-pay analytics important? We are currently experiencing some unprecedented changes in the healthcare regulatory environment, and while most of those changes are linked to the Affordable Care Act, frankly, as it relates to the management of the self-pay balances, some of the changes that we're seeing, particularly with regard to the shift in the payer classes that essentially every hospital in the U.S. is experiencing, really began prior to the ACA. And so the challenge that folks have today is, and this shift and change has been going on for really more than 10 years now, but we've really begun to see in the most recent years a faster acceleration in the direction from some of the hospitals' historically highest paying payers, particularly the commercial markets, to the payer mix in which historically your lowest reimbursement has been, and that's been the patient themselves. And so we'll talk today about why it's important and why it's important to manage that continued shift toward the patient balance, and we'll talk a little bit about some suggestions and ideas about things that you can do from a people, process, and technology standpoint to manage those ever-increasing challenges that we've got. At the same time, the second bullet on the page talks about patient experience and quality, and again, every hospital in the country knows that not only is it important to manage to the changes that are occurring from a regulatory and from a reimbursement standpoint, but the factors around, or the emphasis around patient quality and their experience is equally as important as the financial health of the hospital. And so the real challenge that the hospitals have today is, you're having to manage both ends of that spectrum at the same time. So you're trying to maintain or increase your reimbursement levels at the same time the shift that we just talked about is occurring, but you're also focused more now than ever before on the patient quality levels. And so as certain processes and protocols are put into place, of course, you can't lose sight of the importance on the patient experience and the quality levels. So I think we're ready for the next slide. And so I think we're actually ready for our first polling question. And so our first question to the audience is, how would you expect the patient financial responsibility portion to behave in 2015? So in other words, with regard to the balances after insurance and the self-pay mix, would you expect that in 2015 to increase significantly, increase slightly, stay the same, decrease, or NA or don't know? So if you take a moment to respond, I can share the results with you in just a minute or two. We'll just pause a little bit longer to allow folks to complete the questions. So it's not surprising, and really it's, as we expected, the vast majority of the folks out there selected one of the two. So the audience, by far the most commonly answered question was an expectation to see the patient financial responsibilities to increase significantly, and then really everybody else selected increase slightly. So the entire, or most of the audience today expects the balances after insurance to increase over time, and that's what we would expect. That's what we would expect it to see, and we're going to share with you a couple of slides that are going to demonstrate some of the trends that we were talking about. So this slide here, it's title group plan burden is increasing, and so as you can see, the overall medical cost for a family of 4 has increased in total, and so that's one significant piece of what's happening in the healthcare environment today. But equally, and probably more significant to the hospitals, is that the bottom layer, which is the dark blue section, which is the employee contribution to the premium, is increasing more. And of course that's important because the typical employee in the U.S. today is reaching into their pocket with regard to the premiums significantly more so than they were in the past. And so if you just roll the clock back less than 10 years, the amount of money that the employees are experiencing and the covered folks are experiencing on their health plan is double what it was in the past. And so this slide is simply the annual medical costs that the patients are incurring. And then on the next slide, we've got some similar results. Now this is the non-group plan burden, and we see a similar shift that's trending upward. And so we've got increases. So really what's happening in the environment is, again, this really probably isn't a surprise to anybody that's in the hospital industry, but we've got premiums increasing, so the healthcare costs are increasing, and so not only are the employers experiencing higher costs, but some of those higher costs are being shifted over to the employees, and so the employees are faced with higher premiums on the front end, and by virtue of the changes in some of the health plan designs away from more traditional commercial insurance products toward ones that carry, in some cases, high deductible health plan environments. So not only is the employee paying more on the front end for the premium, but they're reaching into their pockets more at the point of service. And as most folks in the hospital industry realize, not only is that event taking place, but a lot of folks that show up at the hospital didn't think or didn't realize, if they didn't have a high deductible health plan in the past, they weren't expecting a heavy bill when they show up on site at point of service. We've got some metrics on this slide here that really just reiterate some of the challenges that we've been talking about, but the first one up there says that over half of the patient responsibilities are never recorded. Over 80% of the true self-pay responsibilities are never recovered. And not only do we see the shift toward the patient balance, and not only are those patient portions increasing over time, but from a hospital's perspective, the cost and the resources that it takes to collect from a patient versus a payer is substantially higher. And there's industry metrics that to reinforce that third bullet that says it costs 3 times as much to collect from an individual patient as it does from the payer. So not only is your reimbursement shifting from your better paying commercial payers down to the patient, it's costing you more to be able to go out and try to collect less from the individual patients. And we've got a couple other bullets on the page that talk about the Medicare beneficiaries paid an average of over $4,700 out of pocket for their health care in 2010, and that's increased pretty significantly from the start of the century in 2000, 44%. The last two bullets really show the trend that we believe is going to continue, and it, from the first polling question, it looks like the vast majority of folks that are on the call today would agree. In 2007, patient responsibility was 12% of total revenue. These just aren't percentages. I think the important thing about the percentages, it's less about 12% versus the 40% that you're seeing in that last bullet for 2014. I think what we're talking about here is it is a tipping point for the hospital. So when you're faced with trying to collect roughly 10% from the patient, you're going to design your combination of your staffing levels, your processes and protocols and procedures, and the systems that you deploy to collect the 10%. But when you're faced with something that's closer to 50%, and we're at approximately 40%, and we believe that percentage is going to continue to increase. So now you're trying to collect 40% from the patient based on, unless you've been able to keep up with the quick trend that we've seen in less than 10 years. So you're trying to collect 40% from the patients with systems that were designed and resources and processes, policies, and procedures that were designed to collect only 10% from the patient. So I think with that, we're ready for our second polling question. And that is, regarding your overall experience with your hospital, which areas represent the most opportunity for improvement in your opinion? And the options are your revenue cycle systems, which would include IT systems like the eligibility estimation, etc. B, process improvement. C, staff training. D, reporting, or E, all of the above. And again, we'll pause just a few moments to see what the respondents reply with. Give it just another minute here. So again, for us, the responses were not surprising from our perspective. So the best way to describe the responses were really kind of a splattering of responses. So we had 17% of the folks selected the revenue cycle systems in A, 33% the process improvement, 17% staff training, and then a third of the folks responded all of the above. Not surprising from our perspective, because in our experience what we find is that from hospital to hospital, the different types of issues, challenges, and focuses are different. And so while a third of the responders selected all of the above, we've got quite a few folks that are on the call that selected one of the ones up above. And in our experience, that's typically what we see, is that not every single issue and not every single solution works for every single hospital. And so healthcare is produced and consumed locally, and the solutions that you arrive at hospital to hospital are going to tend to be different. And we've got, I think, one more polling question for the group. All right, this is the last one, and then we're going to move into some heavy data analytics. Please rate your hospital's point-of-service collection experience performance, and the The options are A, optimal or industry leaders, B, good but room for improvement, C, average, D, significant changes are needed, and E, not applicable or don't know. I'll give a few minutes for everybody to reply. And I'm going to step out on a branch and predict that we are not going to see everybody select D, significant changes are needed, but I don't want to lead anybody. We'll give it just another minute here. The results are being tabulated. So a little over half selected good, but room for improvement. And we've got 29% that selected average. And so again, not overly surprising to us. Most of the hospitals that we interact with, they realize the challenges that are out there, and they know that there's at least some room for improvement in terms of whether it's either the resources that are involved in the collections, whether it's the systems that are deployed, or some combination of policies, processes, and protocols. So we appreciate everyone responding to the questions. And now I'm going to turn the presentation over to Jeff, and Jeff Toon is going to walk us through analytics framework and talk about some more specific ideas and solutions on how you might better manage your patient population. Jeff?
Thanks, Patrick, and good afternoon again, everyone. I want to take a minute and use the information in the graphic on the slide that's on screen right now to use this and provide us with some framework for the balance of our conversation. The slide on screen right now illustrates some key areas where conversations take place between the hospital and the patient regarding patient financial responsibility. As you all know, these conversations between the hospital and the patient occur every day across all these areas. In many instances, we think we can gain some insight into the effectiveness of these conversations using some analytics and some metrics reporting. Most of the analytics and metrics that I'll talk about today, I think, are fairly straightforward and might even be described as basic. But nonetheless, I think they can be very effective in helping us to understand performance and potentially change or modify some of the operating behavior that's going on within some of these areas. As such, I think the value of self-pay analytics lies really within the ability to identify improvement areas across these areas using some basic analytics and some tracking mechanisms. One other point I would make at this juncture is the point regarding patient satisfaction. While we don't specifically talk about patient satisfaction in this particular metrics or analytics discussion, we do think that a patient satisfaction survey process such as Press-Ganey is a good complementary type of a practice to incorporate with any sort of an analytics and metrics tracking process. The next slide is based on sort of the very colorful and conceptual slide that we just looked at, and it's organized consistently with that conceptual slide, where we have across the top from left to right those 7 conversation areas, and then beneath each of those we have listed 3 metrics that we think are useful in each of these areas in terms of measuring effectiveness and performance. This list, per se, the list of 3 underneath each of these subcategories, is not intended to be exhaustive. There are many other metrics that you could include, and you might even swap the column that you think some of these metrics should go in. You may notice and may be familiar with a couple of these that you see in here, and that's because they're likely incorporated in the HFMA map keys process of measuring and providing metrics and analytics. You may also notice that some of what you see here is not as familiar, and that's actually a point that I want to bring out. It's not so much the specific metrics when you're thinking about a framework. It's not so much which specific metrics do you have in there. The point is rather there's going to be a different set of metrics from one hospital to the next. You may have some overlap if you compared one sort of an analytics framework from one hospital to another. You're going to see perhaps some of the same HFMA metrics from one hospital to another, but you may also see, when doing comparison, you may see some metrics or analytic information that's a little more customized. So there's really no right set per se. It's really what's right for that hospital, and specifically is what that hospital wants to bring to the attention of all of the users of the information. Some things to consider in terms of the point I made about what's the right set of metrics might be familiarity with a particular type of metric or analytic. It might be comparability. If you want to be able to benchmark yourself against other hospitals, you probably would want to stick to more of the HFMA map key variety of metric. Those are going to be very commonly reported. You'll likely be able to benchmark yourself against other hospitals, and so there's really no one size fits all. You're going to have a variety of different metrics, and there may be some overlap. This table and this framework is really a suggestion, and it's a thought to put in your mind in terms of thinking how you might organize a point of service metrics and analytics process. The overall goal is really to create a framework, some rails to run between, so to speak, in a system that can aid in the identification of improvement opportunities, because ultimately that's the value of self-pay analytics. This next slide is one of the areas described in that framework, the pre-registration and scheduling. And I'll just make a note here that this slide, this format, you're going to see this similar format with the other areas that follow. One of the points that I want to make about each of these slides is the way I have put this framework together. You want to try and understand what are the one or two questions in each of these areas that we're trying to answer. And so with pre-registration and scheduling, I think we're trying to answer two questions. Are we pre-registering our scheduled patients effectively? And then secondly, are we collecting payments at the point of service effectively? On this particular slide, the first metric, the actual pre-registration metric, is the one that I would highlight for you in this area. I think it's a metric very widely used. It is a part of the HFMA map keys. It's a good measure and provides insight into how well patient access staff are collecting information and how effective they can be in terms of setting the payment expectations. The other two metrics on the slide are designed to provide similar type of insight as the first metric, and more specifically are measuring or tracking whether an actual payment is being obtained at the time of service for a balance after insurance patient versus a true self-pay patient. The other point that I would make on this slide, and you'll see this on slides that follow, there are some target boxes here to the right. Target setting is always a good idea for any kind of a metric or analytic that you're going to track and that you're going to use with people on the operations side. Target setting gives the people something to shoot for, something to focus their efforts towards. And whether you're using industry standards or you develop your own targets internally, the point of getting some kind of a benchmark or some kind of a target out there with the metric reporting, I think is strongly recommended. The target setting process, one other point on targets, needs to involve the people that are working in operations and that are using the information and the data on a regular basis. The emergency room slide that I have on screen right now is, obviously that's a specific department, and so we'll have departmental information that we'll be able to access and do some analytics on. The analytics that you see on this page talk about total ER payments, but you could just as easily split these metrics and drill into the self-pay ER point of service payment and the balance after insurance ER point of service payment as kind of some further granularity and some further indication of performance. The totals that I have on this slide in terms of what's in these metrics are really just here for illustration. We think that trending total ER payments over time can provide good insight into whether recommended processes, conversation scripts, etc., are being followed by staff and whether they're being effective. If the trends, when you look at this information over time, if those trends don't make sense, the data itself will provide good indication of where to look further for potential problem areas or areas where there needs to be some sort of modification. The targets for the ER department are going to vary widely depending upon the level and the type of service being offered at any particular hospital. So there may be some industry metrics available. In most cases, though, I think you're going to have a hard time with the comparability factor. So development of those targets internally is probably a good place to go, and you can use historical experience or if there's a particular initiative that's being considered or is being undertaken, then those targets can be set sort of based upon those types of parameters. This next slide is still continuing with our conversation around ER point of service payments. The point that I want to make on this slide is you see four different kind of graphical representations of ER collections, and so we're only talking about one data point, and the only change that is been made in these is just the frequency of the the data point. So the first table is a monthly look at ER collections performance. The second is when you start to look at it on more of a weekly basis, and then the two tables in the bottom half of this slide are daily. This particular example, this particular view is a point that I want to make. I think when you give users different perspectives with the same data, you can sometimes get different types of questions that people would think about when they're looking at the data. If you just looked at the monthly ER collections graphic, you might not start to think about some of the things that you think about with the daily ER collections. Some of the questions that come to mind when I look at a daily is what's going on with the highs and the lows. In the instances where there were highs, are these days of the week, particular days of the week? Is this a one account kind of scenario? And then for the days where we have zeros, you can notice there are days where there were no ER point of service collections. You might ask, what was the staffing on those days? What were the hours that day? What was from an operations perspective going on that we had zero collections on those days? Point of service payments by department, similar to the ER, you can evaluate any department within the hospital that is a key entry point from a patient access perspective within the hospital that should be evaluated from a payments perspective, either at the self-pay level or the balance after insurance level. Tracking metrics, in any department is of course going to be dependent on the availability of the data and whether the volume in any particular department warrants developing and monitoring the metrics on an ongoing basis. Areas where it probably makes the most sense would be radiology or outpatient surgery, depending upon how patients register and flow through the hospital. You'll also notice on this slide that there is a prior balance payments percent metric on this page. This can often be overlooked, and I think the point of service is probably the right opportunity to make gains in this area, and so we think having a prior balance payments metric included as part of your point of service analytics is a good metric to include here. All three of these metrics on screen right now combined influence exposure the hospital has to bad debt, accelerated cash collections, and possibly collection costs. So as such, I think these three right here are highly recommended. This is some graphics related to point of service payments, and there's a couple of different points I want to make on this slide. There are three different graphics presented on this page. The first graph in the upper left is the total dollars point of service collections by month, and the example that I wanted to illustrate with this graphic is the red line, the new operating standard. So once you start collecting the information and you have some historical data, some track record to look at, and then if you know that you're putting an emphasis on some some sort of an operational change and that you're using analytics and regular reporting to influence that change, your ability to present information and get an understanding with the people working in operations that, look, we've achieved basically a new operating level. We've been able to, over time, improve our level of performance, and as such, we have sort of a new expectation. And that's kind of the point of that particular example. The second example to the right of that is total dollars point of service collections by department on a month to date. So this information is actually updated daily. It's compiled daily by department, and we've got three data points that were illustrated for users in this graphic. We've got a month-to-date actual by each of the departments that you see listed there. We've got a month-to-date target, and so that target calculates and updates daily during the course of the month. And then we have a third data element, which is the month-to-date target variance. And there's a nice, pretty picture there to the right of that shows blue is actual, red is our target, and then the green, which is plotted against the secondary axis to the right, shows whether we were positive or negative to target. And so, you know, sometimes a combination of numbers and a picture are effective. Generally, I lean more towards the side of presenting a picture versus just a page with numbers or a table with numbers. And that's the point I want to bring out in the bottom half of the slide. You see a table of numbers on the left, and this is day of the week data. So we've got point of service payment actuals, cash and checks, credit cards, and a total. And then we've got targets for each of those days. If you look at the data, except for the two red boxes, you might not recognize that on a month-to-date basis, the performance is dramatically greater than the target, which I think is much more clearly sort of seen in that in the area graphic to the right. The blue is the actual month to date, and you can pretty quickly see there visually that we're doing much better than our targets. Maybe we need to update our targets. But we're starting to get ourselves into a situation like in that upper left graph where we've maybe now gotten ourselves into a new expectation of performance, a new operating standard, and so presenting this type of an informatic or a graphic on a regular basis, I think helps to get that message across to staff. We'll touch briefly here on early out analytics. The sort of overriding question that I think we're trying to address if we're thinking about measuring early out effectiveness is are we being effective at making it convenient for our patients in terms of how they can make a payment. And so the early out success rate, which is measured by the number of payment plans that we might have going at any one particular time, the email statement metric and the online payments metric are three good kind of sample indicators, good measures monitoring patient payment performance during the period of time immediately following the date of service. So, email statements and online payments options should mean greater convenience for the patient, and it should mean, improved patient collections. The experience that we've seen so far is that there is a rush, if you will, an acceleration of payment types that come into these categories. What's a little difficult to see right now is if the overall is increasing. I think it is, but you have to be mindful of kind of looking at what maybe these payment types are replacing that perhaps before you started with email statements or online payments were patient payments that you got by credit card or by a check or maybe even cash at point of service. So I think the point is we see you know, an appetite for this. We see patients like this. It seems to be convenient to have an email statement that they can click on and then go right to a website to make their payment. That was all I wanted to see on that page. I apologize. I lost my place for a second. So the next slide that I wanted to talk about was patient financial advocacy. And we're trying to understand here how effective are we in obtaining funding for either the uninsured or the underinsured, and are we effective at securing a payment? So for these three metrics, I do have targets for all three of these metrics. These are based, these metric targets are based primarily on PatientMatters experience. You'll probably have a little bit of difficulty if you were to go outside to the industry to find some of these targets. So I just make that point as a note. Patient financial advocacy overall we think is successful when patients have access to financial counseling, when they have access to perhaps a financial services center, a patient engagement center, where they can actively engage in a conversation with another person to understand their patient financial responsibility in the different ways that may be available to them to resolve that responsibility. The other piece is, you know, where we have processes and tools in place that can help staff to identify who's uninsured, who's underinsured. A big part of that obviously is Medicaid. So in here I have you know, Medicaid financial advocacy performance, but you could just as easily substitute and look at other payment sources such as auto liability or workers' comp or crime victim, etc. It doesn't have to be you know, just Medicaid, although that's likely to be the bulk of the dollars. If the funding from these other sources represent significant or material opportunity to improve reimbursement to the hospital, then I think you probably would behoove yourself to have some metric reporting around those areas. The overall aim of the analytics in this area really is to provide good measure of how well the organization is identifying patients who qualify for a funding source like Medicaid, and then the subsequent you know, billing performance to those funding sources, primarily Medicaid. It could be some of the others that I mentioned. There could also be a health insurance exchange product.
Yeah, Jeff, I might just add that you know, when you're coming up with your list of metrics that you want to focus on, you know, there are a good many number of them that might actually tell a story beyond the metric themselves. And I think a good example is that last bullet there, timely billing. So the timely billing metric might, you know, it's certainly an indication that would certainly contribute to the net. You know, you'd have a positive, as that metric improved, you'd have a positive impact on net revenue, obviously. You'd have a positive impact on cash flow. Clearly, the faster you're able to qualify and bill an account, that you're going to drive a faster payment. But there's another component to that metric that really is beyond the metric itself, and that is the timely billing situation really, if that metric gets out of control, not only would you possibly see a drop in your net revenue, not only would you possibly see a delay in your cash flow, but on that particular metric, it's also an indication that your staff's incurred a lot of work to be able to qualify an account, but if the billing isn't done on a timely basis, you've not only do you have the negative impact from the metric itself, but you've incurred expenses that don't result in a revenue lift. And so I make that comment because there's a few metrics that we'll go through, and the metric itself I think is important and self-explanatory, but I think it's always worthwhile to step back from the metric itself and to ask yourself the question, what does this metric really tell us about the organization itself, and not just necessarily what does the metric do for us from, and sometimes it might not be a dollars and cents impact either.
Agreed. Thank you, Patrick. Payment plans I want to touch on a little bit. I think the first two metrics that I have here are specific to maybe what we might consider as sort of more traditional payment plan option between a hospital and a patient. The third, medical loan program effectiveness, is perhaps relatively new in the minds of some people. You know, not all patients have the cash at the ready, so to speak, to cover the high deductibles that I think more patients are probably faced with today. So it's important for hospitals, providers, et cetera, to devise some alternatives to help patients resolve their medical bills. So as such, I think we feel that the prevalence of kind of, you know, different payment plan options will likely continue to grow for patients, and the need to monitor with some analytics will increase accordingly. This slide illustrates a couple of things to think about when you know, monitoring payment plan performance. What is the you know, the effectiveness of our hospital payment plan program? What's the number of patient account balances on a payment plan, you know, versus the total of those that are on a payment plan and those are not? And so should we be reevaluating whether we're being you know, being effective in terms of offering that to our patients? Is the plan being effective? Are the accounts being resolved to zero via the payment plan? An important metric to understand. If we're not seeing you know, balances being resolved to zero, if we see some write-offs, then it's likely we need to you know, think about maybe modifying how that plan is being provided to patients. Medical loan effectiveness, similar to payment plan effectiveness. If we are offering a medical loan program to our patients, are we, you know, successfully resolving the balance on those accounts to zero via the loan program? So these are three good metrics to keep in mind, regardless of whether it's a hospital payment plan or a medical loan program. Some type of analytic should likely be developed to monitor performance in this area. Overall, the analytics and what we're trying to do here is we're trying to seek better understanding of the acceptance by patients and the subsequent further adoption by other patients as these programs gain momentum.
And Jeff, I might just add, in this category, it's probably an area where the hospital industry hasn't, or not the hospital, but the healthcare industry itself probably has not kept pace with some of the changes that we're seeing in the marketplace. And so if your typical payment plan is structured such that somebody that's got, say they're trying to meet a copay and it's $500, the payment plan that's can't be any more than 6 months might work in an environment like that. But I think you really have to ask yourself, does a payment plan arrangement work in a situation where somebody's got a high deductible health plan and they're faced with a $2,000, sometimes $3,000 or more that they've got to come out of pocket? And what we're finding with our hospital clients is that many times that payment plan design that was created years ago in a much different scenario and situation doesn't work as well or might not work at all for a number of patients that are working, they're insured, but just by virtue of the plan design that they're under today compared to what they had a year, 2 years, 5 years ago, that same payment plan policy might not work without without partnering with a partner that can provide a medical loan solution.
This next slide, I'm going to do a couple of slides here together related to a medical loan program. Some very simple analytics in this regard. The program in this example is just into being a couple of months old, and so some of the things that we're interested in understanding, is the program getting some traction? Are there patients that are finding this as an attractive option for them? And so we want to kind of look at the overall dollars on the accounts to see if the program is growing. We maybe want to get some additional insight into the percent of the accounts that are getting into a medical loan program by age cohort. You can start to get some insights here. 41 to 55, we're about 27%, 56 to 65, about a fourth of the total population. So you've got, kind of some key indicators there from a high level. You can get into some of the data. I think eventually I think that this information will start to migrate to kind of more of a graphical representation, but the data for now I think is insightful. It's got the loan balances by week, a little bit of information about male versus female, the average loan per patient size. You can see the overall program to date. We're at about $1,300 for the average loan size. You can get some information around marital status and then the age cohort information there at the bottom. This is continuing that same illustration. You've got a lot of very rich data to evaluate, to try to get some insights into your program. What's the percent of accounts on the loan program by credit score? The percent of accounts average medical loan size. We've got some different categories there, and then what's going on with the payments. And so you can see, I think what's interesting in this slide is the credit score data, where you can see that 30% is in the 600 to 699 range, with another 26% above 700 up to 799. So there's a lot of very interesting information. You can start to use this information, I think, as you collect it, really to get a better understanding of if you're tailoring the right program for your patients, and if you're continuing to kind of meet that need that they have in terms of being able to satisfy their financial responsibility. The last couple of last set really of metrics that I want to touch off on is bad debt. I think bad debt is sort of what happens at the end if you're not effective up front with your pre-registration process, with your point of service collections. And so I think when you look at your bad debt information, and bad debt expressed as a percent of gross revenue is a very common metric. But I think you look at this metric sort of retrospectively and go, oh, we should have been doing, something differently on the front end. So you need to keep track of this on a regular basis and kind of circle back to the front end to see if there are changes that can be made. Charity is an important write-off area, but I will comment that charity is going to be specific to the individual hospital, and so charity policies are going to vary, and your ability to sort of compare that metric from one site to another are going to be a little bit tricky. But I do think it's important to keep track of the information internally and sort of benchmark yourself on a prospective basis. Add that information by zip code and by type of service can also give you some further insight, and trending this information over time I think will help to inform some of those front-end conversations that patient access staff is having with the patients. I've got a couple of slides here that are a little bit busy, and I apologize. There's a lot of data, I think, when you get into bad debt analysis, and sometimes it's not always clear what's most important. This is an example of a 12-month data sample where we looked at bad debt by type of service, patient type. We had some age cohort information, and then we looked at some of the dollars by age cohort. So you can start to see, pretty clearly, I think the bad debt is coming from the ER, and you can start to get some indication of kind of how that breaks out in terms of account count, and dollars in those accounts. You see some of that age cohort information presented there in the middle and at the bottom, and then in total as well as by type of service. This next slide is really just continuing with that same example. The difference with this information is that we put a cut on it by financial class, so that we could start to understand, a little bit more clearly where's the bad debt coming from. Clearly, this graphic shows it's within the self-pay. We know from the earlier slide, and it's presented again kind of on this slide, that it's within the ER. But you also start to understand that you've got some other areas there that might be worth looking into, such as commercial. 24% of your total is within the commercial bucket, and so you can start to do some additional drill downs within those areas to get some better understanding. The last point I want to make before we close, and I know we're right at the top of the hour, we're a minute or two over, is once you get your analytics figured out in terms of choosing what are the right set of metrics and analytics that you want to track and that you will want to report to the organization, how are we going to do that? And typically, a dashboard or a scorecard concept is the best way to kind of bring it all together. So I think the points that I would make here would be focus on what you want to bring to bear as being kind of the most important piece of information you want people to see. Secondly, use as many colors and graphics as possible. I think colors help to draw a reader's eye to what's important, helps them to kind of keep that fresh in their mind as to the point that it's important. And so I think, colorful representation with a dashboard or a scorecard is your best bet there. And then I'm just going to close with a couple of comments. I know we've gone over a minute or two here. When building an analytics process, I think you focus on the fundamentals, and I think that means data integrity, prioritization of the metrics for your hospital, standardization. If you're going to report a metric 1 week, don't change the way that metric is reported next week unless that's being communicated in advance. And I think you've got to get user buy-in. I think people have to understand the data, know that it's credible, and that it's something that they can work from. Solicit feedback continuously, periodically reevaluate what's being reported, and if it's being effective, consider changing it up a bit if that's what's needed to keep it fresh with users. And just overall recognize that analytics is iterative, but if you apply it consistently, it's ultimately going to lead to better collections and improved patient satisfaction.